Okay, perfect. So I'm gonna start with acne and rosacea first. It's a very common disease that we see commonly in the clinic. So I'll tell you a couple of facts about it, but I'm just gonna go with the basic to the advanced information about each one of them. So the objectives is to be able to identify, the common acne lesions, how to treat them, and what's new in the literature about acne. So acne is very common. It's actually, I think, the commonest chief complaint in dermatology is probably acne. It's called acne vulgaris, and it's usually happen during puberty, adolescence, but can happen at any age. We see acne, that starts during adulthood, like above the age of 35 or even 40. People who've never had acne during their teenage started to develop acne. So if we think about the pathogenesis of acne, it's multifactorial. Of course, the increase in the sebum production that happens with puberty when the sebum glands are activated from the androgen hormone. Uh, Very common in the clinic. I see a teenage who comes to the clinic with her mom. And then the mom tells me, oh, she has these ton of clogged pores on her forehead. And that same patient, you will see seborrheic dermatitis, dandruff, and also she is about to reach puberty, and that's why her glands are being activated. So very common. And then we have the follicular hyperkeratinization where the skin renews itself, but we don't see that. But add to that the excretion from the skin, the sebum, so that all will clog the pores. We have a bacteria, normal flora in our skin that can proliferate in patients with acne more, lead to inflammation, and then, of course, the inflammatory response. Every hair follicle in the skin is attached to the sebum, sebaceous glands. There are certain exceptions where we see sebaceous gland not tagged with the hair follicles, such as the meibomian glands, Montgomery glands, for example. So these are examples of sebaceous glands not tagged with hair follicles. So the sebum is coming out to the surface of the skin to lubricate the skin and hydrate the skin. But with the skin renew itself and the high production of the sebum during puberty, these all can clog the pores and lead to an inflammatory pustule that can lead to a nodule underneath the skin and rupture and lead to an inflammation that cause scar because the inflammatory cytokines will destroy the fibroblasts that produce collagen and lead to scarring. Do you guys think there is a rule of diet in acne? I think when I was in school, we used to say, don't eat a lot of chocolates. It actually can lead to acne. That was one of the things that we've been told when we were teenage. But evidence-based, yes, we have milk and interestingly skimmed milk. So someone would think that, well, the fat in the milk can contribute to the development of acne. But what happened in the study is the skimmed milk, which was fat-free, had more acne. And that brings you to the point that the hormonal factors that are present in the cow's milk that was actually naturally made for her babies to grow up can activate the sebaceous glands and make them more active to produce sebum and lead to acne. Vitamin B12 now with Ozempic and Mounjaro, we're seeing a lot of people taking vitamin B12. Some people are just looking online for hair, supplements, and they take vitamin B complex. And then I've never had acne when I was a teenage. Why now? So we have to review their medication. Whey protein because it's actually a milk, and then the high glycemic index, which basically a diet that can increase your blood sugars so fast. Anything that has turbid fluid in it, it's called pustule, and the inflammatory red one is papule. So that's an inflammatory acne versus comedonal acne that commonly present with these bumps underneath the skin that we call them clogged pores, and then the blackheads, which is a slightly oxidized part of the sebum that gives the plaque discoloration. You see videos on social media where they squeeze it, it's black, and then it comes out as yellow. The inflammatory cytokines stimulates melanocyte to produce melanin, so that will lead to pigmentations and destroy fibroblasts and lead to, loss of collagen, so that will lead to scar. These things, the pigmentations is more common in our Middle Eastern darker skin individuals. Scarring is common in both ethnicities, whether white, Caucasians, or Middle Eastern. It's important in the clinic to tell me what kind of acne are we dealing with here. Is it mostly papulopustular? I'm going to give topical antibiotics. Is it mostly comedonal? I'm going to give exfoliating agents. If you give someone with comedonal acne, topical clindamycin, which is an antibiotic that is anti-inflammatory, it's not going to help them. They're not going to be satisfied. If it is deep-seated nodules, anything you put on the top of the skin may not reach down and treat the root cause. So you need to give something oral, such as oral isotretinoin. So that we have variants of acne. We mentioned acne vulgaris, which usually during adolescent we can have post-adolescent, infantile, neonatal, acne excoriae, conglobata, and fulminans. The neonatal, you guys know neonatal is from 0 to 1 month, and then 1 month to 1 year is infancy. So it's very common that neonates have pimples on their cheeks. It's called acne, but it's not true acne. It's just a stimulation of the malassezia on the skin that irritates the skin and led to breakout. But the true acne in babies is the one that actually start during infancy due to short-term stimulation of the glands by an androgen effect that was given transferred from the mom. What's post-adolescent acne? So we see this term a lot now on social media. They say hormonal acne, post-adolescent acne. It's an acne that is condensed on the jawline in females mostly and also can involve the neck. Commonly starts a week before the period. Why a week before the period? Well, a week before the period, the sebaceous gland become very activated, especially the ones on that part of the face. So they can have a breakout. Some people even on their cheeks, or she would tell you that every month this side, I'm getting like one pimple a few days before my period. So it's important when you have such a case to ask about PCOS symptoms, ask about hirsutism, hair loss, irregular periods, if she's infertile, if she has dark pigmentations around the neck, the armpits, acanthosis nigricans, because usually it's a syndrome. Acne excoriae is one of the psych diseases where patients just excoriating their face, they don't have lesions, and it leaves scarring. Conglobata and fulminans, they're extreme forms of acne. The fulminans is the one that is associated with systemic symptoms, fever, males, they're very tired. Both of them, they usually happen in patients who have very severe acne to begin with, and you start the patient on isotretinoin. So they they usually get very severe. So you have to hold isotretinoin, give them steroid, and then restart isotretinoin very slowly. We have drug-induced acne, occupational acne, cosmetica, and then acne mechanica. Drug-induced, very board favorite question on the Canadian board, the license exam on the USMLEs. They love this question. What's drug-induced acne? It's a monomorphic. All the lesions look the same, papule or pustules, mostly on the trunk. So number one feature is it's monomorphic. Number two, it's the location. It's mostly truncal. Number three, it's what's the most common medication? Steroid. Commonly, it's by steroid. So patients who are admitted in the hospital for any reason, like seizures or CNS tumors, they get high doses of steroids, or even with chemotherapy, so they can get this type of acne that is thought to be due to the sterile neutrophils. Acne, occupational acne or cosmetica. So occupational is typically when the patient works with heavy oils such as douche mechanics and they're touching their face. They can clog the pores with these products. Cosmetica, I get a lot of patients in the clinic who have pimples only on the blusher area. So that means it actually has something, a tint that clogged the pores. Think it just the product is not heavy. How come it's clogging the pores? It doesn't have to be heavy to clog the pores. Sometimes the ingredient itself has the ability to clog the pores. There is a big list of products that are comedogenic in the American Academy website for dermatology. It's all chemicals, you can review them, but I usually tell the patient when they go to Sephora or other beauty shops just to make sure they take non-comedogenic products. Mechanica is when the you're physically blocking the pores from outside. Sometimes people when they have fractures and they're for a while on a casa and it just clog their pores in the armpits, so they get breakout there. The violin, so someone just basically is called fiddler's neck because they're always clogging the pores with the violin while they're playing, so that also can lead to acne. All right, so We can also classify acne based on the severity. So moderate to severe typically when we have scars. This is just a summary to go over history of physical examination. If you have a patient with acne, don't forget to ask about topicals they've used at home, the cloak pores on the forehead. Ask if the patient is of darker skin color or African ethnicity. Ask them if they place heavy, greasy products on their hair that actually drip to their forehead and clog the pores. It's really important to review their cosmetics, their medications such as B12. B is very, very important medication in the era of Ozempic and Mounjaro. So if the patient has mild acne, we can treat with topicals, including vitamin A derivatives, adapalene, which is also known as differin, tretinoin, the acrotin. They're basically are very helpful to as an anti-inflammatory and also help with follicular keratinization, so they unclog the pores. The benzoyl peroxide is an anti-inflammatory, but also can unclog the pores, can exfoliate a little bit. If the patient has moderate to severe, of course, we will discuss oral isotretinoin. Uh, it actually reduces sebum productions, minimize the pores. It can induce apoptosis in the sebaceous glands, and our nose is full of sebaceous gland. That's why another term on social media is medical rhinoplasty, where basically people are taking isotretinoin to slim their nose because it's full of sebaceous gland, and if you induce apoptosis in them, you will have a smaller nose. Of course, you will have smaller pores because you shrink the sebaceous glands, so nothing is coming out of it. So the exit will definitely narrow after a while. Acne conglobata and fulminants, we talked about it. We have to stop the isotretinoin, give steroids, and then reintroduce it with a very low dose. Typically, high-risk patients, those who have severe acne to begin with, and you start at high dose. Other treatment for acne can include oral contraceptive pills that do have anti-androgenic effect, namely Diane, Yaz, Yasmin. And then we can do the surgical extraction of these comedones. Sometimes I do it in the clinic. I send the patient to hydrofacial and facial cleaning if their face is full of clogged pores and open comedones, just to clean it up. And then we continue on topicals and treatment at home to maintain the result. If you have a scar, of course, combination of treatment, and we've published a good number of articles on acne scars. They have different types. They have box, ice pick, box scar, rolling, atrophic, hypertrophic, can be also keloid. So what kind of scar you have, you will actually decide a treatment plan, but it's mixing more than one procedure together, and it's in clinic. I always tell the patient maybe vitamin A derivatives such as acrotin different can help slightly, but it's not going to do a big change. Let's move to rosacea. So for rosacea, it's a chronic disease that typically starts later. So after acne, like around later 20s, early 30s. However, it can start early as well. We have triggers. There is a rosacea.org website where they actually place so many triggers based on the patient's reported triggers. It was not studied. So a patient would say, well, heat, sun. So they actually combine all of them and they put it in a one website. And then people can go back to the website and review the triggers and see if that works for them. For example, in the website, most people agreed that heat. So in the clinic, I tell the patient, when you take a hot shower and you look at your face in the mirror, do you find it red? Yes. When you go outside and it's hot, yes. So sun exposure and heat are the biggest triggers for rosacea. Other triggers can be differs among patients, such as caffeine, dairy products. They say in the website all kinds of cheese except cottage cheese. But I had a patient who actually ate cottage cheese. She was pregnant and she was craving for it, and then she had a bad breakout of rosacea, a bad flare of rosacea. So spicy food, stress. So review it with the patient and tell them to look for what actually makes their rosacea worse and try to avoid it. Male and female are equally effective. Very common thing in rosacea, they experience tingling sensation in their face because it's a neurovascular dysregulation. Important clinical question in history. دائما نقول للمريض في العيادة هل تحس إنه في تجريس في وجهك؟ الtingling التجريس. This is neurovascular dysregulation. It's a very important question that we should ask the patient with rosacea, and that's related to its pathogenesis. I don't want to complicate you, but what happened is with an increased trip and vasodilators, we get these blood vessels. Rosacea can be very confusing and can be very difficult to differentiate between rosacea and acne in a sensitive skin. So patients with redness and sensitive skin who have acne may look like rosacea. How to differentiate? One of the common things when you look closer to the skin and find dilated blood vessels all over. You ask the patients if they apply topical steroids on their face. If no, then you should think about rosacea. I'll look for other, of course, signs, but this is, I find, very important sign. Of course, the common exam question is how to differentiate between acne and rosacea would be the lack of comedones in patients with rosacea. The phyma, which is the thickened nose, it's typically hypertrophy of the sebaceous gland. It's more in males. And if you look at the paintings in most museums, you will find a lot of old paintings with rhinophyma in known males. So rosacea is actually classified into four subtypes. It can be erythematotelangiectatic, which is basically just redness with blood vessels, and can be papulopustular or combined. These two types that are commonly happening together. The third one is the phymatous, and the fourth one is the ocular, that is in 40% of patients. Okay, so for the subtypes, we talked about it, the erythematotelangiectatic, papulopustular, phymatous, and ocular. So persistent facial erythema, which is basically this redness with the blood vessels. If they ask you in the exam how to differentiate this between flushing, because a post-menopause woman could flush, a patient who is taking a vasodilator such as calcium channel blockers for hypertension can flush. Look at the blood vessels. If you see prominent dilated blood vessels all the time, so this is rosacea. The papule and the pustules of the rosacea is typically involving the central part of the face. If you try to divide the face into three-thirds, so that would be the middle third is the rosacea papulopustular. One other thing is the lack of comedones in patients with rosacea. Can someone have rosacea and acne at the same time? Yes, they can. But I'm also trying to tell you, try to differentiate as much as you can. If you have a patient with acne sensitive skin versus a rosacea skin, like what kind of routine are you going to go for? Because if you use the rosacea, pure rosacea products, you're going to exacerbate the acne. And if you use the acne treatment products such as benzoyl peroxide, you're going to burn rosacea. People with rosacea hate benzoyl peroxide. They can't tolerate sometimes salicylic acid. So you have to be careful with making the right decision clinically because the treatment depends on your classification of the patient's condition. For the rhinophyma, they love to ask about it in the exam. Two common questions is what are the best treatment evidence-based? So number one is oral isotretinoin. We talked about it because it shrinks this hypertrophic sebaceous gland. And the second one is laser or CO2 laser, especially because it's ablate the skin. Some people do electrocautery. Anyway, you have to remove a big layer of the skin. We said 40% of patients with rosacea can have this ocular symptoms, and the most common one is dryness. Some people can have these cysts, chalazion, chalazion, that they put some hot compressors and they open. We need sometimes to send them to ophthalmology, but if in the exam they ask you the most common sign and symptom, the sign is redness. The most common symptom is dryness, and most of the time we have to give them just lubricant, and they will be fine. So these are the four types of rosacea, and we mentioned typically that the first and the second time they overlap with each other. So we've done a network meta-analysis on the best treatment for papulopustular rosacea, and we found that azelaic acid is the best treatment. For most types, you're going to tell them avoid sun, avoid triggers, sun protection. What kind of sun protection is the best for rosacea? Mineral. Why mineral? Because the chemical one typically have preservatives to stabilize the sunscreen that can irritate rosacea patient. So we want something that do not have these stabilizing agents that irritate the skin, such as zinc or titanium. If you add also iron, it gives another layer of protection, but mineral is the best for patients with rosacea. However, if you have a mistaken rosacea with acne and you give them mineral, you're gonna actually flare up acne because it clogs the pores and lead to acne. That's why I'm telling you the balance is really important. And then for the erythematotelangiectatic, you can give something that vasoconstrict the blood vessels, such as promethazine, oxymetazoline. However, these are associated with rebound tenderness. If you have something, you know, a blood flow, and there you're closing it, and then you're reopening it, it's just going to give more flow. So the patient may experience rebound erythema. Sometimes it's important to give these treatment if the patient has a wedding, important occasion, so they can use it. And then we can do vascular laser for the blood vessels. Please be careful. I've seen so many patients who've had a ton of laser sessions, especially PDL, with no benefit because they don't have the flushing. They go to the clinic, the laser is stupid, will target only redness. So if the patient has prominent blood vessels, it's going to work. If the patient has the flushing, and it's episodic, so they don't have the episode right now, and they go to the clinic, get the session, it's useless. The other thing is for papulopustular, we said about the azelaic acid. It's important. I love it. It's my favorite skin ingredient. It's safe for pregnancy, lactation, works for pigmentation, anti-inflammatory, great for rosacea. Tell them about the tingling sensation with the first application, and it goes away with consistent use. It's important to counsel them on that. Otherwise, they will think they're allergic to the cream. Doxycycline, there is a slow releasing dose of doxycycline that present in 440 milligram that we sometimes give, minocycline as well, and then isotretinoin. Be careful with it, very low dose. If you give a high dose, it will make the patient photosensitive and will make the rosacea worse. The phymatous, we talked about it. And then the ocular, we said we're just going to do normal artificial tears and moisturizer, and then we can send the patient to ophthalmology if needed. So I'm done with the first presentation. Now we're gonna move to the second presentation. I don't know how you guys find it. Was it good? Do you guys have any questions about the acne and rosacea?
يعطيك العافية دكتور عبد الهادي. في عندنا تقريبا one question. ما شاء الله تبارك الله، مرة يعني المحاضرة مرة very والله informative. في lecture من دكتورة غيداء بتقول what options for scars other than topical treatments.
So for the scars, typically, as I told you, the scars are loss of collagen. There is no collagen. So we don't have a cream that boosts collagen except vitamin A derivatives, that is, for example, differin, acretine. But they're not going to do a magical result. You have to do procedure in the clinic. Procedure, you can do laser. I usually use CO2 laser, which is very strong, 3 times stronger than fractional, and it give excellent, great results. I combine it with collagen biostimulator that stimulate collagen as well. I do scar subcision, I do exosomes at the same time, and I give the patient a routine that boosts collagen at home. Vitamin C in the morning, serums with sunscreen. At night, I actually keep them alternate vitamin A derivatives with peptides. This is the perfect routine to boost collagen that we can use it as an anti-aging routine, but here we're using it after acne scar treatment to boost the result. I hope that is.
يعطيك العافية دكتور. في سؤال Q&A تحب نخليها في النهاية دكتور، ولا بعد كل محاضرة؟ يعني كل محاضرة والأسئلة حقتها.
That's totally fine. سؤال عن ايش عفوا؟
اوكي، في سؤال بيقول إنه what about topical calcineurin inhibitors for treating erythematotelangiectatic type?
Yes, exactly. So calcineurin inhibitors, such as pimecrolimus and tacrolimus. So pimecrolimus elidil 1%, and tacrolimus is protopic. It present in 0.03% for children and 0.1% for adult. I use them, of course. I use Elidel. Why? Both of them, they stimulate TRP activation, so they cause tingling sensation. With consistent use, it goes away. I prefer to use the Elidel. It's actually less irritating. And for Elidel and Skinorine, most of the time I ask the patient to keep them on the fridge because when they put it on the skin, when it's cold, it does this cooling sensation. It does not burn them. So that's one of the tricks. But yes, we can use them, of course. For not erythematotelangiectatic, for papulopustular. Erythematotelangiectatic, sunscreen and avoiding triggers and these vasoconstrictor that we give topically if needed per occasions. I didn't put a lot of things that sometimes I do in the clinic, such as micro mesobotox. I use mesobotox on the face with Dermapen and with very small plip injections. It vasoconstricts the blood vessels. I find it very temporary, may last for like 2 months. Very common procedure I do during Ramadan because people for Eid they want to look less flushed and less red. It's also a technique used to minimize the pores for brides, for example, but it's very temporary.
يعطيك العافية دكتور. So far هذه ال 2 questions في المحاضرة الأولى.
Okay. You guys are all dermatology residents, students, interns. Let's move to the second talk. Great questions, because these questions are really smart. Okay, let's move to HS. Okay, amazing. Do you guys see the presentation?
Yes.
All right, so let's move to HS, which is my favorite disease during residency and even afterward. I published a lot on HS, so I'm going to give you an overview about it and tell you the update and important things to know. So it's very common, 4% prevalence. Its incidence is unknown because sometimes people get pimples in their armpits and groins and they don't go see a doctor, or sometimes they get treated as, abscess or inflamed nodules. They get drainage and antibiotic and they are sent home without the diagnosis of HS. What's the difference between HS and acne? They sound similar. What happened with HS is the follicle itself is very, very occluded. It doesn't allow anything to come out, and it's very hard to rupture. So common thing patients with HS would say, well, I have this pimple that comes in my armpits or under the breast or in the groin that I try to squeeze out, but it's not open. That's common because there is a thickening around the hair follicle. And what happened with the inflammation when it's ruptured, it forms tunnels underneath the skin. There are systems that we use to classify HS. With the early staging was the initial one, and it was mainly to decide whether this patient will go for medical or surgical. We've published a classification system on phenotype, but I find I think I put it in the slides. So we did a phenotype classification where basically we divided it into follicular, non-inflammatory, and then inflammatory. The follicular is basically when you see double-headed comedones, follicles, mostly in smokers, thin people, and the obese people with the inflammations, they have nodules and deep-seated abscesses. But there are multiple phenotype classifications. This is a classic presentation of an HS patient who smokes. Typically have a lot of clogged pores, superficial scarring that looks like cerebriform scarrings, pustules, and very superficial nodules. They don't have the deep-seated inflammatory nodules, interconnected tunnels underneath the skin. The frictional fruncle is one of the types that happen mostly in obesity, and they think that friction will irritate the hair follicles. So that's commonly in the thighs, under the abdomen. I have a patient with extensive HS just under the abdominal fold. And then the redundant abdomen, and of course, armpits and breast. Extra, or they call it ectopic HS, very rare. And once it been on TV, where there was a patient with very severe HS on her face, and I've seen one case, it's very rare. This is our classification of HS clinical phenotype, where we divided it into inflammatory and follicular. And the follicular one is usually superficial with these double-headed comedones. Genetic is in 1/3 of the patients. They would report that, well, my mom or grandma had these pimples in her armpits, under the breast, in the private area. They don't say probably she had التهاب الغدد العرقية القيحي, but probably they would explain what sounds like a chest. In terms of genes, we've seen a couple of patients and we tried to report this novel variant of MEFV, which is a gene involved in Mediterranean fever. This family had it, and it was something novel variant that we haven't seen before, but it runs in family. Comorbidities, obesity is the most common one, but we can have multiple. I tried to look up the subtype of HS in patients with IBD, and we were able to find that patients with Crohn's typically have genital involvement of their HS subtype, and that can be confusing because is it a cutaneous IBD extension, a cutaneous Crohn's, or is it a true HS? Because usually with Crohn's, you'll have tunnels and fistulas from the gut going to the skin, and the management is completely different. Now, it just impacts the psychosocial impact of the life. We've done a study on absenteeism and presenteeism. People go to work, they suffer, or they don't go to work because of the HS. And also, it's been associated with depression and anxiety. People take painkiller all the time, so they can become abusers, and that can actually lead to suicidal ideation and suicidal attempt. One of the very important hot topics in HS is cutaneous SCC, which is a bad thing because SCC that develops in an inflammation, such as that one that develops in discoid lupus or Marjolin's ulcer, or for example, linear porokeratosis, all this hypertrophic lichen planus. We have so many diseases in dermatology associated with the development of cutaneous SCC. If it is an inflammation, a chronic inflammation, usually in 1/3 it would metastasize. So we need to try to identify it early on. So if you have a patient with a chest in the genital area, try to palpate their groin. So in our study, we found that it's mostly gluteal. Most patients had early stage 3. A big number of the patient, 1/3, had metastasis to the lung, and a big also number, almost 50%, were having palpable lymph node. So palpate lymph node in patients with groin HS to make sure they don't have one of these nodules turned into SCC. The most common presentation is ulcer. We tried in the study to say, how can we prevent it? Maybe we should give the patient HPV vaccine, but what's the relation? Well, when these cancers were analyzed and stained, molecular studies found that they were HPV positive. So maybe there is a role for HPV virus in this population. That needs to be studied in further research. So this is the conclusion of our study. Okay, in terms of the treatment, of course, it needs help from multiple disciplines to give the patient the proper treatment. The inflammation is caused by multiple cytokines that involve TNF-alpha and IL-17 mostly. So TNF-alpha level is increased and associated with increased severity of the disease, and also IL-17. Regarding the guidelines, combination. So you need to give the patient topical, you need to plan them for surgical excisions if needed. If they're severe, you need to give them biological treatment. So I'll walk you through what we do in the clinic. So if we have a patient with early stage 1, just these papules and nodules, we can give them topical clindamycin, we give them benzoyl peroxide wash. I always instruct them about the diet and smoking in a very nice, gentle way, because sometimes patients will be scared of you. If you're from first visit, say, stop smoking, it's the cause. Try to help them stop smoking, but just touch it briefly in the first visit. Do not go through it. I usually do it later on. And I have a couple of patients who successfully stopped smoking. And then after that, we can give them oral doxycycline. Also for course, we can give them rifampin with clindamycin. We also can give them etanercept IV. It will just treat their inflammation. But all these options are temporary. Think about what's the long-term plan. Are you going to plan to do surgery? This is the important message that I'm trying to send here. So we have guidelines on certain populations with HS as well. The British guideline is similar. You start with topicals, you can do surgical, and if patient failed or severe, you give them biological therapies. Surgery, the only curative one is to completely excise the whole area, which is very scarring, and you don't want to do that, but it's the only curative treatment. De-roofing, where you remove the roof. And we do it a lot in the clinic for patients where we insert a probe and then we remove the roof. We just cut the upper layer of the skin. We clean the base from this gelatinous material, like with curettage. That actually helps the patient. And believe it or not, it improved the quality of life of so many patients, even if they're on biologics. Sometimes there is this one area that act up, and we published on that. They have a very thick film around that area. Probably it prevents the medication from getting in, or it's a microbiome environment by itself, so it needs to be open. Patients in the clinic ask about laser hair removal. So in DIAG, Gentle Lace, Gentle Max, Gentle Pro. It's actually effective with meta-analysis study, and you can basically tell the patient to have a session, and then when they have an inflammatory nodules, they can do 2 times on it. My struggle with laser hair removal is number one in Saudi Arabia. Most males can't find a good center that accept males and do their private area. Number two is most centers, they don't want to touch patients with their chest, even if they're in a remission and they have scars. They're afraid that something happened. It's challenging. Clascoterone is basically a new treatment for acne that targets the androgen, and it's been thought that can actually work in patients with HS. But regular treatment in the clinic, we inject with steroid. We give the patient topical clindamycin to use at home. I give them benzoyl peroxide wash. If the patient complains of a bad smell, I give them Rosex, which is a topical metronidazole that we use for rosacea to decolonize the bacteria. I tell them take a shower, clean, dry, put the metronidazole, and that's it. It decolonizes the bacteria, so it helps a lot with the smell. Resorcinol is a chemical peel that is present in certain skincare products. It's actually a peeling ingredient that has been studied in France to be used as a treatment for HS and also help with the scars, the superficial scars and pigmentations. Steroid injection very effective, and there are certain clinics where the nurse would accept a chest patient, do 2 injections, and if they required the third one, she would call the doctor, so the patient can just go and see the nurse for the steroid injection. We talked about the clascoterone that works as an anti-androgen. So one of our studies that actually looked at the ultrasound and showed a thick membrane around the nodules. I'll probably put it in this slide, or I will show it to you later. This is the resorcinol that we talked about. It's commonly available as a compounding ingredient in Spain and also in France. And I have some patients who brought it from outside. It's in a cream. It's very effective in treating glyceriform scars and pigmentations. Systemic for HS, we have so many. So we talked about it. The 2 approved one are biological treatment that we will see in the upcoming slide. Apremilast can be used, which is used for patients with psoriasis, but I don't use it in HS. So the 2 biologics are adalimumab and secukinumab. Also, we published on the what's probably in the pipe and coming up soon. So when we look at the studies of HS, we look at the HS clinical response. That is more than or equal 50% reduction in the inflammatory lesions with no increase in abscess or draining fistulas when compared to baseline. Adalimumab is very effective, but just bear with me for a second, because here when we say effective in HS, we're talking about 40 to 50%. We're not anywhere near psoriasis where we have 100% clearance. But it's good. The problem with adalimumab is what is patients after a few years, they lose efficacy. Why is that? Number one, it's the medication is given more frequently every week. Number two, patients have high inflammatory load, so the chance of forming antibodies is very high. So they lose efficacy after around 3 years. Most studies found that the drug survival is in that period. So do we have anything alternative? Even the real world experience found that patient loses efficacy after a while. It's really rare to find someone on adalimumab for long years and have HS. This is our study where we looked at the film. I reviewed all the ultrasounds of patients who were on biologics and were still complaining on one area that acted up. And I ultrasound these areas and I found this film around it. So we published this as our own sign that can indicate, well, if you see this sign, give the patient the biologic, but plan for surgery at that site because it's probably not going to respond to the biologic. So can we do surgery and operate on the patient and cut them while they take biologics? Of course, it's safe. It doesn't cause anything in terms of increased risk of infection, and it's actually more effective because you're reducing the inflammatory load and the healing is faster. Secukinumab is IL-17, and it's what they used right now most of the time, given the adalimumab may lose efficacy after 3 years, so I start more to lean toward IL-17. Plus, they have similar, closer efficacy to adalimumab. Bimekizumab probably will be approved soon. It's also slightly more effective than secukinumab from the IL-17. All right. right, so I think that's the summary for the biological uses in HS with their, the clinical response of 50% at week 12 or 16. Okay, these are more of a in clinical trials, so I don't want to overwhelm you with it. Which basically right now we have, oral anti-IL-23 inhibitors used for patients with psoriasis, can also be used in patients with HS. We have sonelokimab, which basically another IL-17A and F inhibitor. It's a nano antibody. It showed a great efficacy as well, so probably it's also going to be approved. All right, so I'm going to move to the third presentation of the day. Do you guys have any question about HS?
يعطيك العافية دكتور. So far في Q&A والchat ما في any questions.
Okay, perfect. I will just open the third talk. So we've done two, so we have two more. The two more, I actually made them very straightforward. One, I made it question-based, and the second one, I made it as like interactive cases. So they, because the Scaly one is very boring. It's a very boring chapter. So I tried to put it as questions. Let's see.
Okay, ممتاز بإذن الله. Take your time دكتور.
You guys are great. Friday night, and you're listening to me boring dermatology talk. This is amazing.
بالعكس والله.
Okay. يعطيكم العافية. Thank you, Houriah, for organizing this. You're such an amazing dermatologist. Okay.
الله يسعدك.
So we're doing papillosquamous and then psoriasis. They're actually two separate chapters. I think the chapter that I read the most in my life was psoriasis. It's very common, and you have to know the common things by heart. So let's go over the papillosquamous chapter. So we have all these diseases. So I'm just going to tell you what's common for the exam and how you'll to know about each one of them. We have small and large plaque psoriasis. We have PLEVA, PLC, PRP, pityriasis rosea, the PR, rotunda, and then granular hyper or parakeratosis. For small and large, basically they look like the psoriasis, but they're not psoriasis. So that's number one. They have a CD4 T cell infiltrates in both of them. What's small and what's large? So small is this than 5 centimeter. Is there an exception? Yes, there is an exception. We have two variants of the small plaque psoriasis, which is the xanthoerythroderma persistens, number one. Digitate dermatosis is longer than 5%, that can actually reach 10%. And then we have the large. Important thing to know, which one is associated with the development of cutaneous T-cell lymphoma? Large. What's the percentage? 10 to 35%. So that's important thing to remember. This is the small plaque psoriasis, and when it's digitate, it's actually more than 5 centimeter, but still it's a benign thing. It's very, very, very rare, extremely almost zero, that it will change into cutaneous T-cell lymphoma. And this is the large plaque psoriasis. It looks somehow similar to the CTCL, and it has around 35% of developing, transforming into CTCL. Why is that important? Well, it's important because you need to follow these patients. Treatment for them, both of them, topical steroids, antihistamine, narrowband UVB. You can give methotrexate as well. So we mentioned small less than 5, large more than 5. However, in the small, the exception is if it is digitate, it can be more than 5. The large are also types. So one of the types in the large is the one that is associated with dyspigmentations, telangiectasia. We call it polyderma vasculari atropicans. The word polyderma implies 3 signs on the skin: the atrophy, the dyspigmentation. When we say dyspigmentation, we mean hyper or hypo, both of them. And then the atrophy, the epidermal atrophy. Where do we see polyderma commonly? Radiation, breast cancer radiation. We see it on the breast most of the time. But if we see it on the skin, we have to be suspicious of CTCL or large plaque psoriasis that can actually evolve to CTCL. We talked about the 2 types of the small, and we said the digitate is actually more than 5 centimeter. The large, we have the retiform that looks like network pattern. And when this associated with polyderma vasculari persistence is actually has or carry a very high risk of transforming into CTCL. Here we talked about the risk because it's a high yield for the exam. For small, it's low to zero. For large, it's actually 10 to 35% over 6 to 10 years. If it is retiform variant, it's almost 100%. So that's important for you to remember for the exam, and also remember to follow up these patients regularly. We have PLEVA and PLC, also common. We see them in the clinic. They're a spectrum. PLEVA is thought to be acute, and the PLC thought to be the chronic one. It can be associated with certain infections. Sometimes we give them antibiotics as a treatment. There is a variant of the acute called acute, which is PLEVA, called febrile ulceronecrotic Mucke-Habermann disease. That can be severe variants with ulcerations, fever, lymphadenopathy, and joint pain as well. In terms of the histopath for PLEVA is also important because it's very characteristic. They have extravasation of the RBCs, they have this parokeratosis, heavily shaped. What else is important to remember for the exam? So you will find in the literature that patients with PLEVA and PLC, of course, treated with topical steroids, antihistamines, phototherapy, most of them, and also methotrexate. But the interesting is the courses of antibiotics given to these patients, such as azithromycin, shown to be effective. So the difference between PLEVA and PLC, PLEVA have these vesiculopustular lesions that have this central necrosis, very classic of PLEVA. Okay, so we talked about the predominant cells. So it depends on if it is PLEVA, it is CD8, and if it is PLC, it's CD4. That's also a high yield to remember. The way I remember it, if it has more letters, it's actually 8. Less letter, it's 4. We talked about this acute variant of PLEVA called FUMHD, where patients would have ulcerated necrotic lesions, also general July symptoms, the fever, the malaise, lung involvement, and also bacteremia. PRP, very common, have multiple subtypes. We'll go over them in one diagram in the upcoming slide. Classically, on the skin, they have this orange salmon-colored patches with islands of sparing. And the treatment is oral, for example, acitretin or isotretinoin, and then we combine it with phototherapy, or we can give methotrexate with phototherapy. These are actually the best treatment option for patients with PRP. Of course, you will find biologics, especially IL-17 for some reason, being used in the literature to treat PRP. So you can see the island of sparing, perifollicular prominent, orange color, salmon patches. These are the 6 subtypes of PRP. So we have the adult, the juvenile, and then the variable one, which basically HIV associated one. So in the we have the classic adult. So what's classic mean? It means it's like a cephalocaudal distribution, red, orange, islands of sparing, this very perifollicular keratotic prominence, and the waxy palmoplantar keratoderma. And then we have a typical adult that looks like eczematous lesions with ichthyosiform, especially on the legs. We have circumscribed juvenile, classic juvenile that looks like the adult exactly, and then the atypical juvenile where patients have sclerodermoid changes like, and then finally the HIV associated. PR, very common during COVID with vaccinations, with the recent type of influenza we've seen. We've seen so many cases of PR. It starts as a herald patch and then progressed in a Christmas tree distribution. So you want to remember herald patch, Christmas tree distribution, association with HHV 6 and 7. Some people test for it. We don't test for it. It's not important. Patient just had a reaction to a viral infection. Important in the exam, they ask about for the PRP histopath. I'm just going to go back. One of the common questions in the exam, they ask you how to differentiate between PRP and psoriasis. So psoriasis, we see more neutrophils because it's a neutrophilic disease, and then the checkerboard appearance with PRP. So we talked about the PR. So treatment, nothing other than just reassurance. It's going to go away on its own. We can give antihistamines. PR usually starts as lesions for like 4 weeks and then stable and then go away. So it has around like 3 months natural history. We have variants of PR more for, like senior residents to remember. It can be inverse, usually pigmented in children, vesicular, purpuric, pustular, urticarial, EM-like. And also, if it happens within the first 14 to 16 weeks of pregnancy, it can be associated with spontaneous abortion, but that because the mom had probably viral infection. So HHV 6 and 8, we talked about it in PR. Natural history, we said it takes a few weeks. You have to tell the patients they're gonna get new lesions, then it's gonna stop, nothing will happen for a week or two, and then they will gradually start going away. Rotunda is basically big circles. There are two types of it. The African one was usually very large and hyperpigmented, few lesions, versus the one that appears in Caucasians. It's more numerous. Honestly, I haven't seen any case. It's just basically in the textbook, and we have to remember it because it looks like tinea. The treatment, we have to understand what's going on with the patients because sometimes it can be associated with malignancy. So the high yield question for the exam about rotunda is they put the picture in the OSCE and they ask you about the association. So it's malignancy, malnutrition, infection, or G6PD deficiency. Lastly, the granular parakeratosis. Typically, we see it in the armpits. We think it's a hypersensitivity from products they use. We also can see it in the kids in the genital area, and likely because of powders and products they use to, reduce the smell, antiperspirants or anti-deodorant that can actually lead to this hyperkeratotic papules. Of course, the big differential diagnosis is Darrier and Haley-Haley, and we treat it as Darrier and Haley-Haley. We try to, avoid trigger, remove these deodorant and anti-deodorant and antiperspirants, and then just put topical steroids if needed, very mild potency, retinoids as well, or oral isotretinoin. So the underlying cause we don't know, but basically there is a process of inability of proflagrant to become flagrant, and that results in the retention of the keratohyalin granules in the stratum corneum. Retention of keratohyalin granules in the stratum corneum, often on the exam, they put it in the multiple choices. So remember that when they ask about the pathogenesis of granular parakeratosis. Exacerbating the temperature and the sweating. And we said about it, we said about this because it's important for the exam, the retention of the basophilic keratohyalin granules. All right, so we'll move to the last presentation. Do you guys have any questions about the papillosquamous scaly lesions?
الله يعطيك العافية دكتور. في كان سؤال في المحاضرة اللي قبل في ال HS. Meanwhile, we can wait for the questions في المحاضرة الكرنت. في اللي هو سؤال في ال Q&A. Would acne conglobata respond to biologic since it shares pathology with HS?
Acne conglobata response to biologics?
أيوة, since it shares pathology with HS.
Yes, I can actually, and it's very common that you have a patient with very bad acne, such as conglobata, and also have very bad HS at the same time. Very, very, very common scenario. That's an excellent question. And but I think conglobata and fulminants, they're acute-ish somehow, because typically the patient has very bad acne, and you start them on a very high dose isotretinoin. So the recommendation, if you have an adolescent, 16, 18, comes to the clinic and that person has very bad nodules, inflammatory lesions, he can't even sleep because if he put his face on the pillow, it hurts. Don't start them on very high dose of isotretinoin. Try to go very slow, like 10 for a month or two, and then 20. If you start high from the beginning to get their acne down, the acne just ulcerates and go crazy and lead to erythema and ulcerations. I had a patient, she's a researcher from Kmark, she's from India, and she was seen by another doctor and was actually giving isotretinoin for her severe acne, and she presented to Emerge when it was on consult service with acne fulminans. She even had a fracture on imaging, so it's a bad thing, so they mention in the literature it's common in Caucasians, but we see it in Southeast Asians, in Middle Eastern. with very bad acne when we start high doses of isotretinoin. Thank you so much, Reem, for saying that the lectures are not boring.
ففعلا والله دكتور الصراحة والله we're really enjoying it يعني صراحة والله Friday well spent والله. دكتور
Right.
في عندنا سؤال في الكيو ان اي تحب ناخذ دكتور ولا بعد المحاضرة الأخيرة؟
That's okay.
اوكي في سؤال what's the drug of choice in patient who has acne vulgaris and acne rosacea؟
Excellent. So I usually give them something that treat both, which is azelaic acid. So azelaic acid can treat rosacea and also can treat acne. It's one of the acne treatment in pregnancy and lactation. The problem with azelaic acid, it's very slow acting molecule. The patient needs to be patient with it. And the other thing that I find very common mistake that most doctors, when they give azelaic acid, they don't counsel the patient. أنا في العيادة أقول لهم بيقرص، ثاني ليلة يقرص أقل، ثالث ليلة يقرص أقل، رابع ليلة ما يقرص. You have to counsel them on the what they are going to experience, because if they don't know and they put it on and it tingles, oh أنا عندي تحسس من الكريم، يرميه. Plus you have to tell them you're not going to see result overnight. You need to be patient. I like azelaic acid for those with acne and pigmentation because they treat both, but it's common in the whole routine. I always include them.
Perfect يعطيك العافية يا دكتور الآن ما عندنا questions في الكيو ان اي.
And also doxycycline, if you want to give oral doxycycline, it can treat papulopustular acne and also can treat the tetracyclines in general, treat both acne and rosacea. Okay, so let's move to the last presentation. It's very small and quick. I tried to go over important things for psoriasis, but I want your participation, guys. So I don't know if you want to make it interactive so I can hear you. They can mute unmute themselves, right?
I think they can according للsettings بس برضه في الشات يعني ممكن they chat with us برضه فأنا
Yes, guys.
أيوة
So
أكمل.
let's have fun, uh, and just basically, get to know each other more and hear you guys. I'll just do a quick thing on the psoriasis. So let me do that. Do you guys see the presentation?
Yes.
Okay, so I have a couple of cases. So I'm going to tell you what do you really need to know for the exam for psoriasis, what's high yield about psoriasis. So we get these patients that come to the clinic. So the first question is, how would you differentiate between psoriasis and eczema clinically?
Okay في جواب hyperkeratosis.
Excellent. So the psoriatic lesions, they have this thick micaceous scales. So the scales, psoriasis is basically the Latin term is referring to the scales of the psoriasis because they're silver, they're thick. But the most important thing is if you take a pen, you can actually draw a line around the psoriasis lesions. So it's well demarcated. Eczema is ill demarcated. Number two is this thick scales in psoriasis that we don't see in eczema. Number three is we have clinical signs to differentiate between psoriasis and eczema. So what are the clinical signs? What do you see on the exam?
Okay فالanswer is بيقولوا location distribution eczema is ill-defined papules and plaque psoriasis well demarcated psoriasis affect hair nail joints silvery
Excellent.
plaque scalp involvement nail changes eczema has.
Excellent. So let's talk about the nail. So nail, basically they have pitting, which is dots in the nail in 80% of the patients. They can have subingual hyperkeratosis, onycholysis, oil spots, which is salmon, the most specific one. And the most common one is the pitting that can be geometric or regular. When it's irregular, usually it is associated with alopecia areata. What are the signs in a patient with, we'll talk about it later. Okay, so we talked about the psoriasis, how to differentiate it from eczema. We talked about the association. We said nail, 80%. Joint, what's the percentage of patients with psoriasis who have joint involvement? Joint pain, psoriatic arthritis, which is destructive. That can be oligo, most common, asymmetric. It can be axial. It can be RA-like. It can be mutilans because it's a destructive joint disease.
Okay في percentages في ناس يقولوا 30% رزان
Excellent.
و
So
70.
30%, yes, one third of the patient. Can someone tell me what are the high risk when I see a patient with psoriasis? What are the high risk that can tell me, and I'm putting a clue from this slide, can tell me this patient will probably have psoriatic arthritis?
Okay, في answer من سامية. Scalp psoriasis and nails.
Good job, Tanya. Yes, so scalp involvement, nail or periangual when you have inflamed lesions around the nails. The third thing is genital. That can be, you can divide them. You can say gluteal cleft, glands of the penis. You can see female private area. Anyway, the genital area by itself, the genitalia, the nail or periangual, and the scalp. This is clinically, but there are other things from the history. If the patient has psoriasis for a long time, so since childhood, if the patient is obese, if they have family history of psoriatic arthritis. The other things in the clinic, the enthesitis is basically the most common one, and we screen for it with ultrasound where patients have subclinical inflammation. We can also send the patient for radiology X-ray with a sign that we see is called pinning cupping, pin in a cup due to the resorption of the bone, because psoriatic arthritis lead to bone resorption. Okay, so I think that's what we covered. The psoriasis, the chronic plaque is the most common. We have pustular psoriasis that can be subtypes such as generalized pustular psoriasis, Von and Busch, when the patient has fever and sick. We can also have generalized, localized, so localized to the psoriatic lesions. It's rare nowadays because it's back in the days when we used to apply talc. We can have palmoplantar psoriasis as well. Some people say it's just a separate entity. Okay. So the scalp involvement is associated with psoriatic arthritis. So when we talked about psoriasis in general, and I give you a couple of important information about association with psoriasis. It is associated as well with impairment in the quality of life of the patient, can lead to cardiovascular, the depression, impact quality of life. We use PASI score to assess the severity of psoriasis. What else is important to remember? Treatment, we have biologics, of course. Back in the days, we used to use TNF alpha. We have etanercept, infliximab, adalimumab, golizumab, certolizumab, which is a pegylated and biologic that is preferred in patients with pregnancy because it does not cross the placenta. IL-17, IL-23, and then IL-12-23 is ustekinumab. ايش تتذكروا منها للامتحان? I'm gonna tell you. If you have a patient with psoriasis, look for other association. If the patient has psoriatic arthritis and it is axial, يعني عنده الظهر ما يصحى من النوم ما يقدر يتحرك for 1 hour, back stiffness, ما راح يستجيب بشكل رائع ل IL-23 inhibitors. But that patient with axial involvement will respond better to TNF alpha inhibitors followed by IL-17. Remember that for the exam, okay? The other thing is peripheral, yes, IL-23 works. That's important. And then you have to remember about the association. Does the patient have history of IBD? So I can give something that treat both. Now IL-23, most of them work for IBD as well. So no issue with that. Gazelkumab is approved, risankizumab is approved. Can I give it to the patient if the patient has multiple sclerosis? So multiple sclerosis, you're not supposed to give which one of these categories? And which one is preferred for patients with multiple sclerosis? Demyelinating. Okay, do you want to read the answers, Houriah?
أوكي في جواب من سامية IL-17 inhibitors.
Excellent, good job. So IL-17 is preferred because they thought it crosses the placenta, crosses the brain barrier and may have a beneficial effect in patients with MS. Patients with cardiovascular, cancer, lupus patient, you're not going to give them TNF alpha inhibitors. Why? Because sometimes when patients take TNF alpha inhibitors, they can become ANA positive, so you don't want to give to them when they have lupus. Cancer, of course, you don't want to give it to them. And cardiovascular is controversial. So I summarized for you guys here in this table the approved ones for adult versus peds, and I put between brackets the one that can be also used in psoriatic arthritis. Oral for psoriasis, we have 2 medications. We have apremilast. It comes in a box with the starting set. 10 milligram, that's given like 10 milligram. Next night, we take 20 milligram at night, 10 milligram morning, then 20 morning, 20 night, 30 night, 30 morning until we reach that dose. It activates and increases the cyclic A and B. So it increases peristalsis movement and lead to diarrhea, all patients. If the patients cannot tolerate it, basically because of the diarrhea, we give only 30 milligram a day. Other thing they ask about it in the exam is what's the workup needed. So the needed is BMI because it reduces weight. And you need to ask the patients about depression because it actually can induce, not induce the depression, but activate already existing depression. Deucravacitinib, it's an oral. After 10 years of no approved oral medications for psoriasis, we have deucravacitinib, which is a JAK inhibitor. 6 milligram once a daily can be associated with nasopharyngitis. Spesolimab, which is an anti-IL-36 inhibitor, it's thought to play a very important role in patients with generalized pustular psoriasis. It's given as an IV one dose, can be repeated after 1 week if there is no improvement. The New England Journal study showed the adverse events, and one of the patients developed DRESS as a side effect of the spesolimab. Here I summarized for you guys all the topicals that are used for psoriasis. The newly approved one, the most recent one, are the roflumilast, which is similar to apremilast, but it's topical. When we have intertriginous psoriasis, sometimes it's hard to put calcineurin inhibitors or because it can irritate the skin, or vitamin A derivatives, or put steroids because you don't want to cause atrophy in this area. So you can use something that works by a different mechanism. Tapinuraf, which is aryl hydrocarbon agonist, also approved, and it's been also as well marketed for, flexural intertriginous sites. This is very important. A lot of questions about this in the exam. It's, I think, from 2021 JAD publication, but still they ask about it in the exam. What's your preferred treatment if the patient has psoriasis and faragh? And this game goes on. If the patient has psoriatic arthritis, so you're going to look at the approved one for psoriatic arthritis and psoriasis. If the patient has IBD, if the patient is obese, you basically want to give them something that reduces their weight, because we know that if the patient is obese, the response to medication is not that good, and their psoriasis is severe. So you want to reduce the weight by giving them probably apremilast. It reduces weight because it makes them go to the bathroom. Or you're going to give them something weight-based dose, such as, for example, ustekinumab, something that are the dose is actually increased when the patient has a high BMI. We talked about the MS and the lupus. The other thing is we didn't talk about the hepatitis. So if the patient has positive anti-core and you're afraid that they may have reactivation of their hepatitis, your best options will include apremilast and IL-23 inhibitors. Even if they have active hepatitis, you don't want to give them methotrexate, you don't want to give them cyclosporin. You can give them retinoids, but with monitoring. But the safest ones are usually apremilast and IL-23, and that's a common, very, very, very common question in the exam. Let me know, because psoriasis, I can go for 3 hours talk about psoriasis. I tried just to give you like rapid, important, high